Hi, Assalamu alaikum. It's me, Dr. Muhammad Kazafi, and I am trying to present one very important topic, and it is day-to-day use for the neurosurgical operations when we are doing that. So it is called the somatosensory evoke potential. I just want to talk about the somatosensory evoke potential. In that regard, the somatosensory evoke potential have been in use for decades as an integral method of intraoperative neurophysiological monitoring for spinal central nervous system and vascular surgeries in combination with other mode of neuro and physiology monitoring. Somatosensory evoke potential serve to herald potential and actual nerve injury, or I want to say you allow for the correction to avoid for morbidity associated with surgeries. Several forms of neuromonitoring exist. Somatosensory evoke potential, muscle motor evoke potential, EEG, brain stem auditory evoke potential. This activity I want to present here for to explain this thing in detail, to identify what is the somatosensory evoke potential, and to describe you in front of you an influence of somatosensory evoke potential include the operative changes and pharmacological agents have been used, and also the somatosensory evoke potential interpretation and how potential change may be managed during surgery to avoid neurological injury. So here I want to mention like that, and I want to give you a brief introduction for that, and which is that the intraoperative monitoring act as an alternative to wake up testing to monitor for impending neurological injuries that is avoidable by altering the surgical technique, position, physiological parameter, and or medication. The use of the somatosensory evoke potential intraoperatively began in 1970s, and they were one of the first intraoperative neuromonitoring technique to be used, and this is limited research compared result between cases and with and without intraoperative monitoring. So somatosensory evoke potential is not the new thing, but we have to understand that how we can use it and how it is beneficial for us. So the use of the somatosensory evoke potential intraoperatively began in 1970, and they were one of the first intraoperative neuromonitoring technique to be used. This is a limited research comparing result between cases with and without intraoperative monitoring, though retrospective study suggests outcomes are improved when using monitoring, and somatosensory evoke potential first found used as a indirect indication of motor pathway injury, and clear guideline on intraoperative monitoring do not currently exist. That's why it is important to familiar with common modalities that may be encountered and their implication on surgical management employing. Somatosensory evoke potential in the operating room involve coordination by many members of the healthcare team, which may include anesthesia providers, surgeons, nurses, neurophysicians, and technicians. Somatosensory evoke potential, somatosensory information get relayed with the spinal cord via two main pathways: the dorsal column lemniscal system and spinothalamic system. This dorsal column lemniscal system and spinal column or spinal thalamic system both are important for the information to get the relay within the spinal cord. So the somatosensory evoke potential monitor the dorsal column lemniscal system, which transmit mechanoreceptors or proprioceptor, so they do not monitor the spinothalamic tract. And somatosensory evoked potential have been used as a surrogate for or surrogate of motor pathway function. Though they are not as sensitive or specific for this purpose as motor evoked potential monitoring, recommended use of the somatosensory evoked potential for intraoperative monitoring include them as a part of multimodal approach, and they are generally not the sole method employed. The method from the periphery to the cerebral cortex that a sensory stimulus takes through the dorsal column lemniscal system is as follows. Detection of the stimulus occur via peripheral nerve terminal in the skin, joint, etc. So these terminal are part of the primary afferent nerve which travel from the periphery through the dorsal horn of the spinal cord and project to second order neuron within the dorsal column nuclei in the brainstem. The second order neuron decussate after leaving the dorsal column nuclei and project to the third order neuron in the ventricle posterior nucleus of the thalamus. So the third order neuron from the thalamus project to the somatosensory cortex and various other areas involved in sensory processing. So I want to just explain this pathway. The pathway from the periphery means from the periphery of our body to the cerebral cortex, the sensory stimulus take through the dorsal column lemniscal system is as follows, and detection of the stimulus occur via peripheral nerve terminal in the skin, joint, and the terminal are part of primary afferent nerve which travel from the periphery through the dorsal horn of the spinal cord and project to the second order neuron with the dorsal column nuclei in the brainstem, and the second order neuron decussate further leaving the dorsal column nuclei and project to the third order neuron in the ventral posterior nucleus of the thalamus. So the third order neuron from the thalamus project to the somatosensory cortex and various other areas involved in sensory processing. In this picture, we can appreciate from the periphery, the first order afferent is coming, and then in the spinal cord at the dorsal column, the second order neuron will start and it will take to the nucleus cuneatus in the spinal cord, in the brainstem, and then from the brainstem, this is, you can see the third order neuron, and it is going to the somatosensory area, and you can appreciate here operculo-insular cortex. In the same way, you can see the efferents are coming, which is showing in the red color, and the afferent were in white color. So the pathway I already explained just before, so no need to re-explain it. And I want to mention here the typical somatosensory evoked potential are recorded from an upper and lower extremity nerve pending surgery location, and electrode are placed at multiple sites along the sensory pathway, and compared with the different aspect of that pathway, the evoked potential transmit from the electrode placed along the sensory pathway to the cortex where the waveform is recorded. For example, when recording median nerve somatosensory evoked potential, the electrode may be placed at the Erb's point with it waveform presenting. For example, we took the Erb point, so it with it waveform presenting and peripheral component over the cervical spine to reflect the subcortical component, and are multiple area of scalp to capture parietal and frontal cortical component. So the tibial nerve somatosensory evoked potential get recorded similarly with electrode placed at location to capture various spots along the sensory pathway. Here you can see the somatosensory stimulus is given to the hand, and from here the nerve is taking, the median nerve is taking and taking to the spinothalamic tract, and this spinothalamic tract it is taking to the dorsal column, and from the dorsal column from the spinothalamic tract it's taking to the thalamus, and from thalamus it's taking to the and a sensory cortex, and you can appreciate here in this picture it is explaining very well. So when reviewing the somatosensory evoke potential recording, so it is how to understand, and as I mentioned that before, each spot monitored along the sensory pathway has a typical recording value. For example, a electrode placed at the earth point during median nerve monitoring and would have a value of N9 in a healthy patient. So alternatively, somatosensory evoke potential value can be used to infer the placement of the monitoring electrode and underlying neurological structure presented by that value. So by reviewing the somatosensory evoke potential recording, it is crucial to understand how they get reported and to have a knowledge of anatomic origin of common use recording, and somatosensory evoke potential waveform report as N or P followed by number. N or P correspond to the negative or positive, and the wave polarity and the number present the expected latency of the wave in millisecond. So determined from the healthy population, each spot monitored along the sensory pathway has a typical recording value. For example, an electrode placed at the earth point during median nerve monitoring would have a value of N9 in healthy patient. Alternatively, somatosensory evoke potential can be used to infer the placement of the monitoring electrode and the underlying neurological structure represented by the value. To use the previous example, a somatosensory evoke potential of N9 represent monitoring of the median nerve, specifically at near earth point, which is where the brachial plexus component of the sensory pathway along the median nerve is best assessed. Following are summaries of commonly used nerve pathway for the somatosensory evoke potential monitoring, along with their specific point of monitoring, corresponding waveform values, and what portion of sensory pathway they reflect. You know the median nerve, somatosensory evoke potential, earth point, N9, peripheral nerve, brachial plexus, cervical spine, N13, the postsynaptic dorsal horn of the cervical spinal cord, scalp, parietal, and frontal cortices, P14, cervicomedullary junction, and N20, primary somatosensory cortex. Actually, commonly used nerve pathway for somatosensory evoke potential, along with their specific points of monitoring, corresponding and wave, and the what point of sensory pathway a way reflects. So that's why you know that the median nerve, if we consider, and then I will mention you here the tibial nerve. First of all, the median nerve, earth point, N9, peripheral nerve, brachial plexus is N9 in at earth point, and the cervical spine, N13, the postsynaptic dorsal horn of the cervical spinal cord, and then scalp, parietal, and frontal cortices, N14, and cervicomedullary junction, and N20, primary somatosensory cortex. So this is like that. So the total, if we talk about the other nerves such as tibial nerve, somatosensory evoked potential, popliteal fossa, it shows the N8 peripheral nerve, tibial nerve, sciatic nerve. If we go to the lumbar spine, then N22 and the postsynaptic dorsal horn of the lumbar spinal cord, then there, and the scalp and cortex showing the P39 somatosensory cortex. The issue of concern here, though the minimal class 1 evidence is available to support the use of somatosensory evoked potential or any form of intraoperative neuromonitoring, the use of such monitoring technique has been shown to improve outcome after surgery that could lead to neurological impairment. Evidence suggests that employing neuromonitoring intraoperatively, which is the most common use of the somatosensory evoked potential, can help avoid neurological deficit after surgery, and the lack of class 1 evidence has likely contributed to a death of the guideline indicating the use of intraoperative neuromonitoring. Though it is a routine practice in neurosurgery and relevant vascular surgery where neurological structure may be at risk, the likelihood is that the use of somatosensory evoked potential will most frequently be in combination with other neuromonitoring methods such as motor evoked potentials. Though minimal, the lack of a class 1 evidence has likely contributed to a dearth of guideline indicating the use of intraoperative neuromonitoring, though it is a routine practice in neurosurgery and relevant vascular surgeries where neurologic structure may be at risk. A likelihood is that the use of somatosensory evoked potential will most frequently be in combination with other neuromonitoring methods such as the motor evoked potential, and during intraoperative monitoring, baseline somatosensory evoked potential waveform should be recorded for the patient. Thus, the surgeon anesthesia provided and other surgical team member should be altered if there are critical changes in waveform. So the critical changes include a decrease in wave amplitude by 50% or higher, and or an increase in the waveform latency by 10% or more, and the amplitude of somatosensory evoked potential waveform reflect intact axon within the neural pathway. When the amplitude decreases, there is a concern that the axons are being compromised or functionally lost. During surgery, there are multiple possible causes of decreased amplitude and increased latency of waveform. These include medication, decreased blood flow, changes in blood pressure, changes in temperature retraction, local pressure, cautery, and the operative techniques such as surgical dissection. So, this is very important. The amplitude of somatosensory evoked potential waveform reflect intact axon within the neural pathway. And when the amplitude decreases, they are concerned that axons are being compromised or functionally lost. And during surgery, there are multiple possible causes of decreased amplitude and increased latency of a waveform. So these include medication, decreased blood flow, change in blood pressure, change in temperature, retraction, local pressure cautery, and operative technique such as surgical dissection. Clinical significance: somatosensory evoked potential monitoring is employed intraoperatively to identify and ideally avoid impending permanent damage to neurological structure. Because the somatosensory evoked potential monitoring is employed intraoperatively only to identify and ideally, if I consider ideally, the avoiding impending permanent damage to the neurological structure. but temporary damage you cannot stop. Somatosensory evoked potential waveform changes in response to many different factors, and some of which can cause permanent damage. Anesthetic agents have varying effect on somatosensory evoked potential, which should be kept in mind by anesthesia provider, and the anesthetic plan for intraoperative neuromonitoring should be one that will interfere the least with the consistency of the recorded waveform. And the following is a summary of the effect of common anesthesia at somatosensory evoked potential. Volatile anesthesia cause a dosage-dependent decrease in somatosensory evoked potential and increase in latency. So if used during intraoperative neuromonitoring, maintaining somatosensory evoked potential less than 0.5 is advisable. Though permissive use of higher values may acceptable with sevoflurane, or I want to mention here the desflurane. So nitrous oxide alone decrease the somatosensory evoked potential amplitude while having little effect on latency. However, nitrous oxide potential, the effect of almost all anesthetic on somatosensory evoked potential include other inhaled agents. That's why the barbiturate have a variable but in general mild effect on somatosensory evoked potential. They cause decrease in amplitude and increase in latency. Opioids do not cause significant changes in somatosensory evoked potential, though a small reduction in amplitude and increase in latency may present. This scenario is more common when giving opioid as a bolus rather than as a continuous infusion. Propofol can increase somatosensory evoked potential latency and decrease amplitude, though these changes stabilize over time and do not preclude somatosensory evoked potential from being recorded. So here different drugs have different effects. Etomidate have varying effect of somatosensory evoked potential depending on the site of generation. It causes increased amplitude of the somatosensory evoked potential but decreased amplitude in subcortical somatosensory evoked potential. It can be used to increase cortical somatosensory evoked potential amplitude during surgery to better detect changes. Ketamine and similar to etomidate increase the amplitude of cortical somatosensory evoked potential. It has not been found to affect latency or subcortical somatosensory evoked potential. Alpha 2 agonists such as the clonidine and dexmedetomidine do not affect somatosensory evoked potential and are considered good agent to use when intraoperative neuromonitoring is needed. Neuromuscular blocking agent have no direct effect on the somatosensory evoked potential. So the purpose of this topic here to show you different drugs showing differently their pharmacokinetic effect over the patient for the somatosensory evoked potential. So generally an inferred total intravenous aesthetic, which I say TIV or TIVA, inferred total intravenous aesthetic, is desirable when using somatosensory evoked potential intraoperatively when, yes, so generally inferred total intravenous aesthetic TIVA is desirable when using somatosensory evoked potential intraoperatively when reviewing the above effect of various anesthetics on somatosensory evoked potential, which are most changed by inhaled agent. If inferred total intravenous anesthetic is the chosen anesthetic plan. So additional monitoring to access the depth of the anesthesia could be considered, and many surgical fraction can alter somatosensory evoked potential, though the most time sensitive of these are ischemia, surgical manipulation or of the structure, cautery, dissection. Ischemia could result from pressure retraction, cleft vessel, manipulating structure, and dissecting a certain area may compromise neurological structure and tract and leading to a loss or distortion of evoked potential signals that, if not corrected, could result in permanent neurological deficit. And a cautery, if used too liberally, could compromise blood flow and or directly injure or nerve or spinal tract. Various physiological parameters influence somatosensory evoked potential. Example of these include hypothermia, changes in partial pressure of carbon dioxide, decrease in partial pressure of oxygen, and decrease in arterial blood pressure. So these various physiological parameters influencing also the somatosensory evoked potential. So hypothermia increases the latency of somatosensory evoked potential and has an consistent effect on somatosensory evoked potential amplitude, and decrease in partial pressure of carbon dioxide primarily affecting somatosensory evoked potential. For example, hypocapnia to partial pressure of carbon dioxide value under 20 mmHg causes a small decrease in somatosensory evoked potential latency. Hypercapnia does not have significant, if any, effect on somatosensory potential. Progressive hypoxia to level that can cause ischemia to neurological tissue cause decrease somatosensory evoked potential amplitude and increase latency, though changes are not apparent. With mild decrease in partial pressure of oxygen, drops in mean arterial pressure affect somatosensory evoked potential primarily if mean arterial pressure falls outside of the autoregulatory range and involve neural tissue becoming ischemic. Management of a critical somatosensory evoked potential changes require excellent communication amongst the surgical team and timely response to avoid any neurological injuries. The anesthesia provider would review the patient's vital signs, paying close attention to the mean arterial pressure, partial pressure of oxygen, functional inspiration of oxygen, FiO2, and temperature. So they should always review the medication the patient have received and any recent changes to the anesthetic management that may contribute to somatosensory evoked potential changes. The surgeon should pause and review the surgical site and any recent changes to it. So this could include newly placed clip on the vasculature, retractor, or overly aggressive dissection close to the neural structure, and ideally quick identification of the cause. Changes will lead to action to address the problem and the return of somatosensory evoked potential signal to baseline. So the anesthesia provider should review the patient's vital sign, paying close attention to the mean arterial pressure, partial pressure of oxygen, and FiO2 and temperature. They should also review the medication and the patient has received and any recent changes to the anesthetic management, and they may contribute to the somatosensory evoked potential changes, and the surgeon should pause and review the surgical site and any recent changes to it. This could include newly placed clip on the vasculature, retractor, or overly aggressive dissection close to the neural structure. Enhancing healthcare team outcome, intraoperative neuromonitoring, specifically somatosensory evoke potential, provide a valuable method of identifying impending neurological injury and avoiding it in vulnerable patient. The entire surgical team should be aware of and involved in the use of somatosensory evoke potential and their management, as this will lead to better patient outcome. And this collaboration includes clinician, nursing, and surgical assistant. Although it is the anesthesia provider and the surgeon's role to address physiological and or physical changes that could cause somatosensory evoke potential changes. The other member of surgical team include nurses, neurophysiologists, and technician should be aware of and able to assist in doing this, as it will ensure the best outcome for the patient. Nurses should feel comfortable in identifying abnormalities and immediately report the finding of the clinician. The available evidence supporting somatosensory evoke potential is primarily level 3, level 4, and level 5 evidence. These are very few randomized controlled trials focused on somatosensory evoke potential use. However, somatosensory evoke potential have been in use for decades, and thus there is a wealth of historical data available to support their use and efficacy. Epidural spinal cord stimulation has emerged as a successful treatment for chronic pain disorders such as failed back syndrome, complex regional pain syndrome CRPS, which is called the complex regional pain syndrome, and peripheral vascular disease. Cervical spinal cord stimulation is less commonly utilized but also has proven effect for pain syndromes such as upper extremity complex regional pain syndrome, intractable facial pain, angina pectoris, and post amputation limb pain, while thoracolumbar epidural electrodes are commonplace with the local anesthesia and conscious sedation, so the patient may communicate with the surgical team and confer the region of pain are satisfactorily treated. Placement of surgical cervical epidural lead requires general anesthesia for reasons of safety and patient comfort and the need for the head immobilization. Although modern multi-contact electrodes have been expanded over capability for manipulating the distribution of stimulation current postoperatively, the initial location of the electrode lead is the predominant factor which determine whether stimulation will be effective for the treatment of the painful region. Moreover, stimulation of the region not involved in the pain syndrome may cause patient discomfort and therefore limit the therapeutic efficacy of the ultimate treatment by altering the tolerance schedule of stimulation parameters. Since paddle type electrodes are placed in the epidural space via partial laminectomy or hemilaminectomy, it can be difficult to control their medial lateral trajectory, and intraoperative fluoroscopy is helpful for estimating lead laterally but will not ultimately confer if one or both sides of the spinal cord will receive clinical significant stimulation. Consequently, after the surgeon's best effort to position a paddle electrode, there have been need to develop a methodology to objectively confer the location of the cervical epidural electrode without patient's cooperation. So somatosensory evoked potential have become a mainstay of neurophysiological monitoring in spine surgery due to their high sensitivity and specificity for identifying spinal cord injury and proven ability to reduce new postoperative neurological deficit, and the potential of the somatosensory evoked potential to assist with localization in the nervous system has been shown by their ability to identify functional region of the human cortex during brain surgery. So several studies have demonstrated that the somatosensory, or I can say the spinal cord surgery, reduce the amplitude of short and the mid latency somatosensory evoked potential, and this is decrease of primary somatosensory cortical activity may contribute to the analgesic effect of spinal cord surgery and or spinal cord stimulation. We have taken further advantage of our routine somatosensory evoked potential monitoring to correctly lateralize and optimize electrode position during cervical and cervicomedullary somatosensory spinal cord stimulation surgeries. Data from 44 patients undergoing somatosensory evoked potential monitoring during cervical laminectomy or hemilaminectomy for placement of the replacement of dorsal column stimulator were reviewed, and leads were positioning laterally or just off midline and parallel to the axis of the cervical spinal cord to effectively treat it. That was most common a predominant unilateral pain syndrome. So during somatosensory evoked potential recording, the spinal cord stimulator lead was activated and intensely increased in the increment of 1.0 volt to the maximum of 6.0 volt. Unilateral reduction or abolishment of the somatosensory evoked potential amplitude was regarded as an indicator of the lateralized placement of the stimulator. A bilateral diminutive effect and somatosensory evoked potential was interpreted as midline or near midline lead placement. Epidural stimulation abolished or significant reduced somatosensory evoked potential amplitude in all patients undergoing placement for unilateral pain syndrome. So in 15 patient electrode were repositioned intraoperatively to achieve the most robust somatosensory evoked potential amplitude suppression using the lowest epidural stimulation intensity. In all cases where significantly unilateral reduction in somatosensory evoked potential was observed, patient reported post-operatively sensory alteration in target location predicted by intraoperative somatosensory evoked potential changes, and placement of the cervical spinal cord stimulator for bilateral pain syndrome often result in bilateral although asymmetric somatosensory evoked potential changes. In no cases where a significant changes other than those induced use the device to directly stimulate the dorsal surface of the spinal cord observed, and no case of new postoperative neurological deficit was observed. A case for analogy, a representative case, which is the 52-year-old man who presented with bilateral jaw, shoulder, and arm pain, underwent placement of the cervical stimulator with desired midline placement, upper extremity midline somatosensory evoked potential generated by stimulation of the right and the left median nerve demonstrates significant bilateral amplitude increase in response to SCA at 2 to 3.8 volt, providing electrophysiological confirmation of sufficient midline electrode placement, and this technique, which utilize established routine somatosensory evoke potential recording, does not need extra training, not it a significant time to the procedure. So we are, after knowing that of continued advancement in somatosensory, spinal cord stimulator lead technology, and that are the message, or which is the effort in lateralization, could chance be obviated by placing multiple parallel leads or little aparted paddle leads with, I mentioned there the one poly rows of embedded electrode attachments. In cervical spine, the potential for after laminectomy instability is greater than in thoracic spine. So we feel that if there is a less exposure with the small laminectomy and the limited ligamentous disruption is prudent, and it is adding the cost and risk of infection. Aside that, placing more hardware in the cervical epidural space to treat predominantly unilaterally pain syndrome arguably exposes the patient to add further neurological risk. Somatosensory evoke potential can safely, easily, and successfully tell the lateralization of the epidural electrode, and corresponding stimulation include that paresthesia in patient we are doing the cervical or cervicomedullary spinal cord stimulation. Continuous somatosensory evoke potential monitoring could help or will be used to provide neurophysiological observation of final electrode positioning by altering the surgical team to an unintended movement of the electrode during anchoring and closing step. So that's all just for the somatosensory evoke potential from my side at this moment. If any information I will get more, definitely I will represent this lecture again with more extra details. Thank you so much. Please support us, like us, and share and subscribe. Thank you so much. See you in one another in a good lecture.